important, interesting topic, status of therapeutic plasma exchange in acute and chronic liver disease. Dr. Chandana Reddy, please.
Good morning, everyone. I would like to take you to this topic of therapeutic plasma exchange in ACLF for acute and chronic liver failure. I would take you through it on the definition, the pathogenesis, and the rationale behind the use of plasma exchange, the adverse events and review of literature, and the recommendations for the future. So before going to the role of plasma exchange, we need to understand the definition of what are the key defining features of acute and chronic liver failure. Throughout the world, there are several societies which are actually having different definitions for the East and the West, and the Far East Asian countries also have different definitions. But the key defining features of all the definitions are that the patient has underlying chronic liver disease, either cirrhotic or non-cirrhotic, and then they have an acute insult in the form of alcohol or a viral reactivation or a Wilson's flare or autoimmune flare, and they have a rapid deterioration which leads to development of a liver failure in the form of jaundice, increased INR, and ascites and encephalopathy developing in the span of few weeks. And then this has a very high short-term mortality, and they also have a component of extrahepatic organ failure. And this is driven by an intense systemic inflammatory response syndrome and leads to systemic organ failure with a very high mortality of 30 to 80%. But it can be reversible in certain situations treated early. So these are the two main definitions which are followed world over. One is the APACIL definition, is the Asia Pacific Society, and the other is the European Society, where Asian Society says that it is an acute hepatic insult with jaundice and coagulopathy and ascites and encephalopathy occurring within 4 weeks in a patient who has a chronic liver disease but no history of decompensation. And then they grade it with the different score called the ARC score. Based on the ARC score, they grade it to grade 3. The European Society says that it is again in a chronic liver disease, either compensated or decompensated cirrhosis, but they have to have a extrahepatic cause of insult, not a hepatic cause of insult, and like an infection or a varicose bleed or anything. And the extrahepatic organ failure is given more importance as compared to a hepatic organ failure in a European. So this is again another North American society also has its own this thing, but the main difference is that it should be the first episode of decompensation in the case of our Asian society, and the insult should be only hepatic, and the liver is central to the pathogenesis of their failure. Later they may have extrahepatic organ failure, and it should be the central core of the problem. Whereas European countries say that it should be predominantly extrahepatic organ dysfunction or extrahepatic organ failure, which then leads to subsequent organ failure and high mortality. But we seem to understand it as a spectrum of illness, where the Asian Society definition actually picks it up the problem much earlier. So if you see the Asian definition, probably by the time the bilirubin is up to 5, till beyond 5, we are identifying it. We are able to identify it. Whereas the European definition says up to 12 milligrams, you don't label it as liver failure. And you have to have kidney failure or some other organ failure to be identified as a acute and chronic liver failure. So the European definition and the North American definitions, we probably tend to identify this illness much later in the course of the stage of illness. And probably that's the reason why most of the treatment modalities like your plasma exchange or other things are not helping these patients, because they are started much late in the course of the illness. So nowadays, the World Society leaders are all coming together, trying to get a consensus and trying to see if they can redefine this definition so that we can have better studies and we can try to intervene early in the course of the illness and try to change the outcome. Coming to the pathogenesis, it's very important to understand the pathogenesis before we can understand the role of plasmapheresis. So the most important part of the pathogenesis is an intense systemic inflammatory response syndrome, which is caused by the activation of the PAMs and the DAMs. So in a patient who is already cirrhotic or has a CLD, they have an immune dysfunction and have a lot of intestinal dysbiosis with gut translocation, leaky gut, which can lead to production of pathogen-associated molecular patterns. Along with that, because of the necrotic liver cells and the insult which causes the hepatic damage and further necrotic of the liver cells, that leads to production of damage-associated molecular patterns. And these two together activate the innate immune system, which leads to a cytokine storm-like picture with a significant release of cytokines are released, and that leads to a severe inflammatory response syndrome. This is followed by immune exhaustion and anti-inflammatory response syndrome, and leads to a immune failure or immune paralysis, and that leads to development of infection and subsequent organ failure. So it all starts with the systemic inflammatory response syndrome. It's again the same thing which shows that DAMs, PAMs, and the immune dysfunction because of cirrhosis, leaky gut, all of them together lead to cytokine storm. then followed by a CARS, then immune paralysis and organ failure. And also there is an impaired regeneration of the liver. And there's also a lot of production of vasogenic mediators which cause endothelial dysfunction, leading to vasoconstriction and tissue hypoperfusion, leading to organ failure. Again, there's a lot of reallocation of the nutrients and the metabolic structures to the immune cells because of hyperinflammatory response. And that leads to metabolic failure and less supply of nutrients to the tissues and the other organs. That again leads to mitochondrial dysfunction of the organ level, leading to again dysfunction. And also hyperimmune status leading to immune paralysis, leading to infections. This leads to end organ failure of more than other, apart from the liver also. Another very important factor which has been implicated in the pathogenesis of ACLF is the von Willebrand factor. They found that in patients with chronic liver disease, either acute and chronic liver disease or even in ALF, there's an increase in the levels of the von Willebrand factor has been found. And this is a lot of negative detrimental effects on the organ functions and the coagulation factors. So they feel that because of the multimers of the von Willebrand factor, which combine with the platelet rich, and they form platelet rich microthrombi in the sinusoids, causing something like a traffic jam or a occlusion of the sinusoids. And this leads to disruption of the flow and exacerbates the tissue injury and delays the liver repair. So this is one of the important factors which has come up new and being studied much more now in the pathogenesis of acute and chronic liver disease. So coming to the management, so whenever we're managing a patient of ACLF, we need to identify that the patient has ACLF. First of all, diagnose it early, treat the acute insult, whatever is the precipitating factor, assess the severity, identify the patient has the systemic inflammatory response syndrome, and because you have to start treating the patient much before he can go into the systemic inflammatory response syndrome or go into the CARS phase of the illness. Because once he goes into the organ failure phase or sepsis and infection, then the outcomes are not going to be very good. So we have to have that golden window period, which is in the first 4 to 7 days of the onset of the insult. That's the period when we have to intervene and treat the patient. Then we can probably change the outcome of the illness. So how does the plasma exchange help here? So plasma exchange is nothing but a plasmapheresis followed by replacement of fluids in the cause of 5% albumin or FFP. It non-selectively removes all the high molecular substances even up to 50,000 kilodaltons. So it can clear all the inflammatory cytokines, growth factors, vasomediators, coagulation factors, antibiotics, everything is removed from the circulation. And it can decrease the concentration by 63% if you use one plasma volume exchange and up to 90% by 3 plasma volume exchanges. So now, when we come to the discussion of role of plasma exchange in acute and chronic liver failure, I will deal with the following. What is the rationale behind using plasma exchange? So like I told you, after the pathogenesis, first is the cytokine release. So plasmapheresis will non-selectively remove all the toxins and inflammatory mediators like bilirubin, bile acids, ammonia, lactate, glutamine, inflammatory cytokines, free fatty acids, all these are removed. So when they are removed, the damage done to the organs is less. Second thing, it also removes the von Willebrand factors, which are although large molecules, the multimers are removed by the plasmapheresis. That again reduces the clogging of sinusoids and improves the perfusion of the kidney. It also removes a lot of the vasogenic mediators, improving the vascular tone, improves the SVR and BP and the hemodynamics, and improves the organ perfusion. It also improves the function of the endothelial mitochondrial cells and also improves the monocyte function. By doing all these things, it also improves in the end, improves the organ failure. It also increases the amount of anti-inflammatory cytokines and the growth factors. So by all these methods, the plasmapheresis helps, theoretically at least, it should help in improving the condition of the acute and chronic liver failure. So we have two ways of doing the plasma exchange. One is the centrifugal method or the membrane method. Centrifugal method is done using the apheresis machine, and it is much more efficient and it takes shorter period of time, and it has better hemodynamics because we use a lesser blood flow in these patients. And the membrane is it's more easier to do because we can use a normal dialysis machine for it, but it requires a longer time. The efficiency is only 30%, and we need to use some kind of anticoagulation like citrate or heparin. But again, the risk of inflammation because of the membrane use is always there. And most of the studies which have been done in acute and chronic liver failure have used membrane type of plasma exchange. Like I told you, the important thing is the selection of the timing of the treatment of plasmapheresis. So you have to start plasmapheresis in the window period of the 4 to 7 days of onset of the illness, because that's the time when the cytokine storm is there. And if you don't prevent it or you don't remove the cytokine storm at that point of time, that's going to progress and go on to develop CARS, immunoparalysis, sepsis, shock, and multi-organ failure, and very poor outcomes. So in ACLF, the role of plasma exchange is in a patient who does not respond to standard medical therapy in the first 24 to 48 hours as a bridge to spontaneous recovery or a bridge to liver transplant. Say the patient is already gone beyond that time, but he has not availability of the organ at that point of time, and you can just support him at that period with the plasmapheresis, then maybe you can take him later for a transplant. Or if the patient has no availability of the liver transplant, you can try plasmapheresis in the initial phase of the illness. What is the volume? Normally, high volume has been used, plasma exchange has been used in acute liver failure, but in ACLF, most of the time studies have used either standard volume, that is 1.52 times the plasma volume, or even low volume has been tried in one study from CMC Vellore. Where is the Velo protocol, where they've used it in alcoholic hepatitis precipitating ACLF, and they've used only 0.5 times the plasma volume exchange per session for daily for 3 days, and they've used centrifugal plex, and they've given it for 3-4 days along with a small dose of steroids. So, and the intensity of plex in most of the studies has been guided by the response to treatment and not a fixed protocol like 3 days or 5 days or whatever. They've seen the response of the patient, then they continued accordingly for 3 to 4 sessions of plasma exchange. And higher volumes are not shown to be very beneficial because they can have their own risk of complications with a high volume, and adds little to the efficiency, because after more than 3 plasma volumes, the removal is not as well, it's not a linear relationship between the volume that you give and the removal of the toxins. And very important, we need to assess the response, whether your patient responding to your plasma exchange or not. So what are the things which tell you how the patient responded? One is, of course, improvement in the hemodynamics, the organ failure scores, and the hepatic encephalopathy will start improving, reduction in the lactate, ammonia, ferritin, improvement in the mitochondrial function, macrophage function. And one important thing I noticed is that the increase in the amount of the interleukin-1 receptor antagonist levels have found to be increased. And this is a very good indicator of that the patient is responding to your plasma exchange, and reduction of other cytokines, and a reduction in the von Willebrand factor level or the activity. And there are other things which can tell you about the non-response, because it's very important for us to see the patient is not responding. We should go early to the liver transplant and list him for the transplant. So a person who has a high baseline lactate, elderly, more than 2 extrahepatic organ failures, encephalopathy grade 3 to 4, ascites, MELD more than 30, or high other organ scores, sepsis-driven organ failure, so infection has led to the organ failure, late initiation, or high hepatitis B viral load, or rebound increase in the cytokines after 2 to 3 sessions, or a decrease in the anti-inflammatory cytokines. All these indicate that patient is not responding, and you need to think of going for liver transplant. Utility of exchange is seen in patients who already have signs of brain herniation, or already past the window period and has more than 2 organ failure and infection and all that. Then the plasmapheresis may not be of much use. It is contraindicated in patients has hemodynamic instability, active sepsis, and has a recent GI bleed. In the study done by Santosh Kumar and all, they've seen the von Willebrand factor levels, and they found that at the time of discharge, the patient had significant reduction in the von Willebrand factor levels, and those who were surviving, compared to those who did not survive the plasma exchange. So we have some markers as of now, which will guide us whether the plasma exchange is helping us or not. The replacement fluid is most often has been used has been fresh frozen plasma. We know the advantage of plasma over albumin and albumin over plasma. I won't go into the details. And plasma exchange has also been combined along with most of the studies which have been done in China and India on ACLF have combined plasma exchange with other modalities like a HDF in patient of HRS and a patient with bilirubin absorption, patients of hyperbilirubinemia. They use plasma perfusion along with plasma exchange for hepatic encephalopathy, and they also use with MARS also. And we know the complications of plasma exchange related to the vascular access, the procedure related, like they can have allergic reactions and hypocalcemia related complications, hypo or hypervolemia. They can have allergic reaction in case of membrane plasma exchange. They can have thrombocytopenia, especially in centrifugal plasma exchange. They can have a loss of platelet count, and also if you have any heparin, you can have HIT and anticoagulation induced thrombocytopenia. And because of the fluid you are going to give the plasma, you can have TRALI, TACO, transmission infections, and all the common erythroid abnormalities that you can see. But the challenges with the plasma exchange is that you're also going to lose a lot of growth factors, regenerative factors. You may also lose inflammatory cytokines, immunoglobulins also will be lost along with the inflammatory cytokines. So now they also identify certain other different plasma separators, which is called Evacure, where they've found a smaller pore size. So only the low molecular cytokines are removed, and the immunoglobulins and all are remain in the circulation. This is a summary of the studies which have been done on ACLF, and most of them have been done from our part of the world, like China and India. These are some of 20 studies, which are studies, and of them only 2 are randomized controlled trials, and both are from China. And the four I've highlighted are from India, which are all case cohort studies, retrospective cohort studies. And all the Chinese studies have followed the Chinese definition of for ACLF. So it's not uniform. Second thing, most of them, all of them are in fact 100% are on HBV related reactivation of hepatitis, whereas Indian studies have all been on alcohol induced reactivation and worsening of the ACLF. And most of them have used a mixed combination of plasma exchange along with some other modality also that has been used. And they've all used standard volume or low volume of plasmapheresis. So these are the details of these two RCTs, where they found that this survival without transplantation 3 months was significantly better in patients where they've used plasmapheresis versus standard medical treatment in both the RCTs. And it was also seen at even at 5 years in the Quinn et al. Study at 2014. In the Indian cohort studies, which were done in India, alcohol was the main reason for the ACLF. Again, survival without transplant was seen to be better in patients with the CMC Fellow study by Dr. Santosh Kumar. Whereas the two other studies were done from All India Institute by Dr. Santosh Kumar Swaroop and Dr. Ramakrishna from PJ Chandigarh, they showed that there was a difference, but it was not statistically significant. Though the short term of 30-day mortality was lesser in patients with the plex, but the 90-day mortality, they did not show a statistically significant difference in these two studies. This is the Vellore study, where they said that the survival outcome of 1 year was significantly better in patients with plex compared to standard medical treatment. And in patients who had renal failure also, they had improvement in the renal failure on doing plex for these patients. But the limitation of study is a very small retrospective study. And they also gave a small dose of steroids of 20 mg per day for 2 weeks and 10 mg per day for 2 weeks for along with for the alcoholic hepatitis. This is another study where it was done in ILBS for Delhi, where she has studied the ACLF patients. They have studied the plasma exchange and FPSA, and they found that they had a higher resolution of inflammatory markers, and they also found lower rate of liver failure related deaths and cleared inflammatory cytokines, and damp and everything was all removed from the circulation in these patients. So they found that the IL-1 receptor antagonist levels were significantly increased in patients who responded to plasma exchange. This is a meta-analysis of the same studies, and they concluded that there is a biochemical improvement, there is a survival benefit at 3 months without transplant, and etiology specific outcome, and most of them have been done in HBV patients, but it's still not yet recommended by guidelines in the ACLF as of now by the world societies. This is another meta-analysis done in this year, 2024. Again, predominantly in ACLF patients of around same studies only which I showed you, they have been taken for this meta-analysis. And they found that there is improvement in short-term survival in 30-day and 90-day survival is there. And around 2 to 4 sessions per patient were done, and only 2.7% of them received transplant. But if you analyze only the RCTs, there was no significant difference between survival in the exchange group versus the standard medical treatment group. And impact of combinations with other assist support devices, we don't know what's the impact of those. They've been used in most of the studies. And most of them have used the Chinese definition for this thing, and the Indian studies have used the Asia Pacific definition for this thing. So because of the heterogeneity in the definitions, heterogeneity in the patients, we cannot really conclude much from these 10-20 studies that we have. So what are the limitations of these studies? One is that ACLF and ALF combined is in most of the studies. No good quality studies, most are retrospective cohort studies, and varying definitions of ACLF are used, so difficult to interpret the results. And most of them have been in Asia, and etiology has been HBV related, and most have used standard volume, and there's no consensus on how much volume and timing and the intensity to be used. And they've used other supports also along with the plasma exchange. And all of them have shown biochemical improvement, but no translating into clinical outcome or survival outcomes. So what we recommend for the future is that first we should have a global consensus definition for ACLF, good quality trials, and telling us the ideal timing and the type and the volume of plasma exchange. And we need to know subgroup probably based on the etiology and the grade of ACLF. And we need dynamic scores to tell us whether the patient is improving or not and predict the response to plasma exchange so that we can list them for transplant early in the course of illness. And the role of combination therapy is still not yet clear. As of now, the European Society does not recommend plasma exchange in any phase of the management of ACLF. Whereas the Asia Pacific Society say that it's a promising tool as a bridging therapy. You can use it once the recommendation. Maybe for Wilson's disease or autoimmune flare also you can use it in specialized liver units. And a combination of these with other therapies may potentiate liver regenerations. But nobody has given a 1 or a 1A or 1B recommendation for this modality. Even the ASL Diametrical Society also does not give any recommendation regarding plasma exchange. But again, the ACLF Society says that in a patient who has single organ failure, ACLF is single organ failure, especially if it's brain or the kidney, you can use a combination of plasma exchange with CRRT in the early phase of the illness and improve the condition of the patient. In the patient does not have an organ failure, but he has class 1, class 2 or early mild form of disease. There also you can use it as a bridge to spontaneous recovery. If the patient has grade 3 illness also, but you're waiting for the transplant, you don't have transplant availability immediately. As a bridge to transplant, probably you can try plasmapheresis in the early phase of the illness as an organ support. Nowadays, they're using instead of plasma, people have started trying replacement at the 5% albumin because they feel that in ACLF there's a dysfunctional albumin. So by replacing the dysfunctional albumin, you're improving the outcomes. It's a small pilot study which was done as part of a larger study called the Apache study, which is going to be published probably next year. So they did a 10-patient study and they found that by using albumin as a replacement fluid, they did around 6 sessions of plasma exchange on day 1, 2, 4, 6, 8, and 10. And they found that it improved the albumin functions, circulatory functions, renal, cerebral, liver functions, and systemic inflammation all improved. And but they gave FFP after each session to replace the coagulation factors, and they gave IVIG every 2 sessions of 400 mg per kg to replace the lost immunoglobulins through the protein. This is the Apache study, which is being done in around 30 to 40 centers across Europe and North America and Canada. And they're going to give 5% albumin as exchange fluid. And they're going to check for the 90-day transplant-free survival in ACLF patients
Madam,
who have 1 to 3 organ failure.
Conclude the.
Yeah. So take home is ACLF is an immune dysregulation with the intense systemic inflammatory response syndrome with multiple organ failure and a very high mortality. Liver transplant is a definitive treatment with improved outcomes, but it is limited by shortage of organs and lack of access. And you need non-transplant alternatives to improve outcomes in ACLF. Plex has a strong pathophysiological basis for use in ACLF because it dampens inflammation, improves liver regeneration, and can provide a bridge, a supportive bridge to transplant or recovery. Published literature shows survival benefit for Plex, but is of poor quality with many deficiencies. We need RCTs to confirm its role, timing, dose intensity, and which subgroup of patients are going to benefit. It can be considered for use early, that is in the golden window period, and in less severe disease as bridge to transplant or recovery, and when transplant is not possible. Thank you.
Thank you, madam, for your elaborate presentation. Now we'll have a quick question and answer sessions. I request the speakers, Dr. Pavan Kumar, Dr. Sunil Pandya, Dr. Lakshmi Narayana, and Dr.